Hey everyone, so we're going to go over the diabetic medication spreadsheet. And these are kind of blocked in colors here. So we're going to talk about these right here first, which are the insulins. So we have our Aspart and Lispro, which is Novolog and Humalog. We have our regular insulin, which is short acting, our intermediate, which is NPH, and then our long acting, which is Lantus, Glargine, Detamir, Levemir. So these two here, our short-acting and intermediate-acting, our regular and NPH, are typically used together, and that is due to their onset and their peak and their duration. So a lot of people that are on these regular and NPH are older patients. They give themselves maybe 3 shots a day, and then they're done with it. So with these medications, they have a very strict diet because of these peak times and the way that it is. They peak and then they go down in the duration. They have to have breakfast, lunch, and dinner at the same time every day because of the peaks, and then they have to eat approximately the same amount of carbs every day. And so sometimes that's easier for patients that want to be on a strict regimen. It does make it a little bit easier for them in some cases, and mostly it gives them, they have to do less calculations, and they have to do less shots. Okay, they have to have less shots, insulin shots. These are a little older, but these medications, but they are still used widely. And then remember the short-acting, the regular insulin, this is the only insulin that can be given through an IV rather than as well as sub-Q. Okay, so this is the only one that can be given IV. The other two medications are usually used together, and that is our rapid, which is our Novolog and Humalog, our rapid acting, and then as well as our long acting. So our long acting in this particular case, when they're used together, is being used as a basal dose. And so it keeps that blood sugar down throughout the day. The duration is 24. I believe it's actually like between 22 to 24 hours, depending, but there's no peak. So it just brings that whole blood sugar level down slightly. Okay, and the onset is 1 hour. So with that, this does not take care of high blood sugars, and it does not take care of meals. So with these long-acting insulins, this patient also uses the rapid acting. So they use the Humalog or Novolog to cover their high blood sugars, as well as cover the carbohydrates that they're going to be eating in each meal. So as you can see, there's a lot more shots that they take. So they'll take a long-acting shot in the morning or the evening, depending on their, the doctor and their decision. You can sometimes take 2 shots of Lantus. So you might see 2 shots of this in a 24-hour period. And then they're going to be giving themselves a shot with every meal that they eat. Even if they eat a snack with carbohydrates, they're going to be giving themselves a shot of Novolog to cover those carbs. This is where carb counting is very much in play. And then also if they have some high blood sugar, to bring that blood sugar down to a normal setting, they will use also this rapid acting. So there's a lot more shots involved with rapid and long acting. Okay. Now, we know the implications for these and the purposes and the action. We've already gone over that. So some general nursing care for the insulins are, of course, monitor the blood sugar. So if anything, this medication you might not give enough insulin, which means that they have their blood sugar doesn't come down as much. And so you might want to call the doctor to say, hey, blood sugar is only going down 40 points from 240 on this particular sliding scale. And so you might change the sliding scale. But then on the flip side of that, you might be giving them the dose that's too much, and in which case they might become hypoglycemic. So for general nursing care, we're going to use the sliding scale for correction dosage, and the correction dosage sliding scale can either be the fast-acting Novolog or Humalog, or the rapid acting or the fast acting, sorry. Rapid being the Humalog and Novolog, and then fast being the regular insulin. So you can see both of those insulins in sliding scales, but not the other two insulins, okay? We need to also monitor labs for, acidosis. We're gonna monitor that potassium. We're gonna monitor the hemoglobin A1C. And then we're also gonna monitor the patient's mental status. Is there any changes? Because these are very good signs and symptoms that a patient is either hyper or hypoglycemic. So if they become severely hypoglycemic, it would be seizures and tremors. But if they are hyperglycemic, they're going to be fairly weak, have polyuria and polydipsia. Okay. We need to educate these patients on medication, administration of the sub-Q injections, and on sick days that we talked about, and how to make adjustments. We need to rotate that injection site. It causes fat molecules or globules underneath the skin if you're constantly poking the one site with the insulin, and then the absorption will decrease. You won't be able, the insulin just won't absorb subcutaneously. And so they need to know the importance of rotating their injection sites. Again, with that patient education, stress and infection, how it increases the insulin requirements. And then vomiting for patients that are diabetics can be really quite problematic, especially if they're on the long-acting insulin, because if they've got a constant basal dosage going on and they're vomiting, maybe they have gastroenteritis, then they can't consume any carbs. And yet they still have that bowl, that basal that is working. So that basal can slowly bring their blood sugar down to an unsafe value. Okay, so this can be problematic. If you have a situation like that and their blood sugar is going down, at home, they should be told to maybe even just put some of the glucose gel, have glucose gel with them all the time, and they can rub it on the inside of their mouth because that absorbs glucose quite well when you put it just on the inside of their cheeks. And then to maybe turn off their or not, if they have a pump, they can turn off their pump. That's easy to do, but they need to call their doctor and let them know what's going on. Maybe they need an anti-nausea medication. But this could be a very potential serious problem with vomiting in diabetic patients on insulin. Okay. Specific nursing care for these patients. So when they are taking the prandial dose, for example, you want to make sure that the prandial dose is given just before the meal comes, maybe 15 minutes before. You don't want to give it too early because then their blood sugars will start to drop. And this prandial dose, remember, is specifically for the food that they're eating. The Lantus, you want to make sure that that's given at the same time every day. Okay, and then some drug-to-drug interactions. We already went over them in the other PowerPoints, but just as a reminder, ACE inhibitors can decrease the insulin requirements. Sulfonylureas also help with the diabetes. The beta blockers and alcohol can lower blood glucose, or alcohol can lower blood glucose. The beta blockers can block that signs and symptoms of the hypoglycemia. Okay, and then the diuretics can also raise blood sugar because of that dehydration, possible dehydration. So now let's go over to the PO medications. So the ones I really want you to look at are these three right here: the biguanates, the DPP-4 inhibitors, and the sulfonylureas. And remember, they work in different areas. The metformin reduces the production of that glucose in the liver. The Januvia increases the insulin secretion, as well as decreases the glucagon secretion in the alpha cells. And then the sulfonylureas, they stimulate those beta cells to release the insulin. This is very common. So is metformin, very common. All three of these are actually very common. These are the ones we don't see very often, but these are the three primary ones. The nursing interventions for this are basically the same for insulin. you're going to educate them on monitor, and yourself, you're going to monitor them for signs and symptoms of hypoglycemia. Patients in these medications are all type 2s, and so it's great for them to have a log of their blood sugar and food intake, so that the doctor can make slight adjustments to their medications. Okay. Many of these medications too are used with renal failure, hepatic dysfunction, and heart failure due to the med accumulation due to hypoglycemia. So they obviously have some issues with mild damage to the kidneys and the liver. So remember with hypoglycemia, so if they are hypoglycemic, where is that glucose and potassium, right? So where is it? Is it in the cell or is it in the vascular system? So with hypoglycemia, this glucose and potassium are typically in the cell, okay? Regular insulin, remember, for DKA patients, if need be, and those beta blockers and ETH mask the cells of hypoglycemia. Causes of hyperglycemia, I feel like I'm repeating myself over and over again, but still, steroids, thiazide, diuretics, hormones, and the stress response from infection. So this is where we have a couple of different differences. So the biguanides, the metformin, this definitely has the most side effects, but it still works really, really well. So people are prescribed this a lot, but it does definitely have most side effects. So let's get into some of them. So right here, so this is the metformin. So special nursing considerations for metformin, GI-related diarrhea. So you want to monitor their bowel sounds. They can have vitamin B12 and folic acid deficiency due to the altered absorption. It's easier for them to go into lactic acidosis, and so they might have more periodic labs drawn. And definitely contraindicated with severe infections, shock, kidney damage, and so on. There are some metformin tablets that are immediate release, and they need to be taken with breakfast, dinner, so forth. And then otherwise, they can take the extended release tablets. So they don't need to take only the immediate release, do they need to take with food, basically. And then drug-to-drug interactions are going to be alcohol, cimetidine, that increases the risk of lactic acid, iodine contrast. So if they are going to be, if they do have to have some iodine contrast, then we need to hold these medications for 48 hours prior to the iodine contrast. So typically what will happen is they'll have them hold their diabetic medications and they might switch them over to insulin. Okay. But that'll be an MD order. Okay, so now let's just kind of go quickly over here to the Januvia, which is the DPP4 inhibitor. Same general nursing considerations. This Januvia is nice because it's a once a day tab with, and it doesn't have to be taken with food. It's really well tolerated. Look, there's like nothing here. So hardly any side effects for this. The sulfonylureas, again, the same thing. Take 30 minutes before breakfast. With the sulfonylureas, there can be some weight gain. Whereas with Januvia, there can actually be some weight loss. So people don't necessarily like these because of the weight gain. And then there are some additional interactions with the Januvia, which is alcohol can actually cause major nausea, vomiting, and palpitations, and then hypoglycemia. So whereas some of them, it's like it depends on the patient. With Januvia, there's a much higher risk of that. Even NSAIDs themselves can increase your hypoglycemic effect, and beta blockers, even though we've talked about them with insulin and so on, they can mask that hypoglycemia and inhibit that insulin release much greater. Okay, so these medications here are for your learning knowledge, but like I said, we're just going to concentrate on those three. And then over here, we do have our glucagon and then our D50 IV push. So we've already talked about this. The glucagon IM is typically given at home because there's no IV access, whereas the D50 is typically given in the hospital when they cannot take any oral fluids or juice or candy to bring up their blood sugar. And they have an IV access, or if they are disoriented or confused, even if they can drink, we'll give them the D50. We rarely give them the glucagon IM in the hospital. And part of that reason to remember is that with the glucagon IM, this stimulates that hepatic production and turns that glycogen into glucose. And so we're putting extra stress on the liver here, whereas the D50 is just straight D50 glucose straight into the vascular system, increasing that blood sugar nice and quick. Okay. Now with the glucagon, it actually has to be reconstituted. So it actually comes in a powder form. And you know why that is because we've talked about this before. If it needs to be reconstituted, it means that it will not last for very long in a liquid form. Okay, so many patients, including myself, when I used it once on my son, with the panic of your loved one having a seizure, which my son had, and a very low blood sugar, you forget to reconstitute it. And that's exactly what I did. And that is actually a very common thing for the first time use of a glucagon. So when, if you do go into pediatrics, or even for adults, if their wife, spouse, friend used it on them because their blood sugar was low, don't be hard on them because you're in a stressed state, and it's often that first time use that they don't reconstitute. So what are you doing? Just like what I did was I just gave my son saline. That's it. I just gave him an IM shot of saline, which obviously did not do any good whatsoever. So what do we want to assess? We want to assess signs and symptoms of hypoglycemia, neurodeficits, and seizures, right? Once that person is kind of awake, conscious, oriented enough where they can drink juice or eat, once that blood sugar is up, we always want to give them a combination of protein and carbohydrates. So example, like a turkey sandwich or a peanut butter sandwich, because that fat, when you have to give them fat and carbohydrates, because the fat, it helps elongate that blood sugar to be higher. So the fat slows the absorption of the carbohydrates, so the carbohydrates are released slower into the body. So that's what we want. We want to keep them nice and steady. Okay. When giving either the glucagon or the D50, we need to frequently check their blood sugars because they could have rebound hypoglycemia, or we could have just given them too much and now they're hyperglycemic. Okay. Both of these medications, due to the fact that they are to bring up blood sugar fairly quickly, you can get nausea and vomiting and so on. And with the glucagon gun, you can get an anaphylactic shock. With the glucose, typically not. Okay. And then again, with the glucagon, some drug-to-drug interactions would be warfarin, phenytoin, and epinephrine. Not really concerned though, right? I mean, it's good to know that stuff, but if your patient is unconscious and at the point of starting a seizure, are we really concerned about this? Not really, because we're concerned about saving their life. So we can deal with these medications later, and if it has like an increased effect or a decreased effect of these particular products, right? Okay, so that's it. I hope that helped. And let's see here. Have a great day.